Hello and welcome to Community Matters, a podcast from the Canadian Association of Community Health Centres. I'm your host, Hilary Leblanc. Today I'm joined by Lee Clark, the CEO of Victorian Healthcare Association, Simone Heald from North Richmond Community Health, Andrea McLeod from Better Health Network, and Tassia Michaelis from Whole Step Health. They are here from Victoria, but down in Australia, down under. I won't do an accent. We're so happy to have you here for this cross-cultural learning moment. How are you all feeling? Good, not too much jet lag. Good. Well, we're very, very happy to have you, and it's been an amazing opportunity learning from you today, and I'm very thrilled by our conversation and happy to share it with our audience. Lee, I'll start with you. Can you tell us a bit about VHA, its history, and the work that you do?
Great, thank you. So the Victorian Healthcare Association is the peak body for Victoria's publicly funded health services. So similar to your Canadian association, our membership spans a bit wider than just community health. It also goes into our public hospitals and some of our other non-bed-based services, bush nursing. So there's a much wider range, but our primary role is to advocate for the sector to ensure we've got good policy settings, really good funding, and that our services are well set up to meet the needs of Victorians in Australia.
Amazing. And now, since you mentioned there is alignment between the two of us, and of course we are heavily focused into community health centres as a Canadian association of them. So can you tell us a little bit about the history specifically of community health centres in the Australia Melbourne region?
Yeah, great. So community health in Australia was established about just over 50 years ago across all of the Australian states and territories, I think almost all of them. And then over a period of time, particularly towards, I think, maybe the late 80s and the 90s, most of the states closed down their community health centres, but Victoria retained them. So we have the very luxurious position of still having this really lovely model of service direct to community, based in the community and underpinned by the social determinants of health. But we are the only state in Australia. We have 21 what we would call independently registered community health services, meaning they're standalone. And then we have about 55 community health services that are embedded in local hospitals. So that means that across the state, we've got coverage almost everywhere. So community health is present for all Victorians.
Wow, that's incredible. And I'm curious as well, because like I mentioned, we might be CHC focused, but there are other types of organizations that are part of VHA, correct? So can you tell us a little bit more for anyone who's curious about what makes up that, sort of authority and association?
Yeah, what the mix is. So there are about 71 public hospitals. They range from some of our largest metropolitan hospitals down to our small rural health services. As I mentioned, 21 independent community health services. There are about 15 bush nursing centres, and then there is a whole range of the non-bed-based services. Patient transport, Royal Flying Doctor Service, very unique to Australia, as well as ambulance and palliative care as examples. So we call them our non-bed-based services, but an integral part of Victoria's public health offering. For the VHA, our membership spans all of that, and together we have just over about 100 members altogether, and collectively the sector is about a $32 billion sector. So it's a large sector in the scheme of things in Victoria.
What is bush nursing?
Bush nursing is a fabulous construct in Victoria. So these are nurses that are running very small clinics in what would be remote areas of Victoria. So there's usually one or two nurses on site. They've got specialist training that allows them to do emergency management and emergency services, and they're often the first responders in situations such as fires, floods, car accidents, when the local ambulance provider might be anywhere up to 45 minutes to an hour away. So they stabilise, manage until emergency management, which is what you would call it, until they arrive on site and they can be transported. But they also do a range of other local services like supporting elderly with meals. They do some great innovative yoga classes and vaccinations and the like. So they're not dissimilar to community health. They bring care close to home, but it's a nurse model.
That's so interesting. Thank you. Because I was just I read that in the lovely book that you provided with so much information. And I was like, I don't know what that means. Do they do nursing in the bush? I was very the bush being a rural area, of course. Yeah. So thank you for that information as well. Now, funding was a big part of our conversation we had before, interest and even as, from the Canadian landscape, we find it very interesting that our funding looks so different province to province. So I'm curious, how are the organizations that make up VHA funded funded within the landscape?
Great. So it's super complex, which I think is not. I think we share.
Yes.
that challenge across both countries. So we are both, irrespective of what type of health service you are, almost all are both federally and as well as state funded. So when we say state funding, we're talking about the equivalent of your provincial model of funding. So our services that are primary care, which is our general practitioner or physician services, our mental health services, our disability services, and our residential aged care, our aged care services, are all funded at the federal level. So that is federal government directly providing funding on the ground for people to access care. Then we also have our National Health Reform Agreement, our NHRA, and that is a negotiation between federal and state over who will cover what proportion of care. So at the moment it is a 55-45 split between the federal and the state government on who will cover hospital services or the acute component of care in Victoria. And then we have Victorian only or state only funding, which is the funding that underpins the viability and the sustainability of our community health centres. So our community health services have core community health funding, which we are regularly advocating for it to be uplifted. It doesn't keep up with inflation and indexation and the like. And then they layer on top a suite of services that best meet the needs of their community. And that might be through grant programs through the state government, or it might be some of those federal programs that I described. So it's tricky.
And tricky here as well, as you heard today, but very different. And now I'll open it up to everybody because you've been here for a few days. And I'm curious, first of all, how has it been? First of all, not only from like the CHC landscape and who you've visited, but I think I saw Niagara Falls was on your itinerary. Have you all been having a good time?
We have.
You have?
We have, and the hospitality and the welcoming we've had from everyone has been incredible.
Amazing.
Just so warm, so much sharing of information, just lovely.
Okay, good. I'm glad to hear it. I did joke and say to one of your colleagues that I've never seen us break out churros before. So we really are pulling out all the stops for your group because that doesn't usually come to this conference. So I'm thrilled you're here for that joke. So I'm curious, tell us a little bit about the community health centers you visited and what you've been able to learn so far. Chassie, if you want to start.
Yeah, we visited quite a few. Niagara Falls. Yesterday we went to Flemington. Mm-hmm. We've been to Quest. And Gateway? Was there any
Gateway.
other one? I think
8. We've been to 8.
Yeah, we've been to quite a few. Look, I think part of the learning is we share a lot of similar challenges, but there's also vast differences. The biggest learning for me has probably been what's missing in our context, and what's really strong here is the focus on housing.
Right.
Housing stability equates to health. Mm-hmm. We do have service providers that do provide housing, but they're not well integrated into the health system, and housing hasn't really been seen as one of the key determinants to good health. Mm-hmm. One of the stabilizing force.
Yeah, 100%. Well, I think we tend to have this mantra, and it comes with the social determinants of health, but like if you're scared about where you live, if you do not feel that sense of security, everything else can just sort of go to the wayside, right? So I think that is something we have, but I did get the sentiment that, it is still a struggle to get, the funding so that like for the government to understand that is such a need.
Oh, it's the underlying factor.
Of course.
So, my thinking now is if you can't stabilise housing, any other, the chances of any other intervention will fail.
Yeah.
So you're ineffectively wasting resources. Yeah. Stabilise what is key, and then you're able to work with people to get the best outcome for them.
100%. Did you have any other learnings you wanted to share?
Some of the things that we heard about are quite innovative, and there are a couple of little things that I was really interested in. One was having peers in the emergency department. That was an amazing idea, something I've already written back to my team and said, here's something that we need to consider. And I think that in Australia, as here in Canada, we're seeing more and more emergency department presentations, especially for people with mental health and substance use disorder. And so to have that peer that can help navigate, to help settle somebody down, but also to broker the relationship and some of the conversation between the clinicians and the client is a fantastic idea. So little gem right there. And the other was when we were at Centre Francophone and looking at their integrated intake. So the way that they do central intake, just some of the innovation behind that and the automation. And I think the opportunity that we have to use AI and automation differently. And I really love that. And in fact, I think most of our group were really
into that.
Got really excited when we heard about that.
Fair. Any other learning?
I guess in Victoria we talk about the social determinants of health as the community, as part of our service provision and as a community health sector, but I really felt like I saw it right in front of my eyes in some of the services. And there were a couple of the services that we visited that really just sort of hit my heart. And one of them was homelessness is certainly evident in Australia, but it's very visual here. And it was at Gateway where they have an outreach team that goes out to the encampments, and the work that the Gateway team did with their community is something that I'll always remember. And then Quest as well with the peer workers. And so I just feel like you can really feel the work that the staff are doing on the ground and the services and the impact that it's having with community members. Helps.
Yeah. And so, I'll stick with you. Did you want to mention or highlight any other of the similarities or differences that you've noticed in our landscape? I know we touched on like housing and different things, but was there anything else that really struck out in terms of those similarities or major differences between our two areas?
Well, I probably was surprised when I came that how alike your system is the same as ours in relation to your funding and you know, some of your government policies. Certainly I come from the organisation that has the injecting room, and it's been interesting listening to the services talk about the closure of the consumption rooms and the impacts that will have within your community. So it will be, certainly from Australia, we will watch the impact of that, and you know, it's certainly an area that we have to manage as well with our people that use drugs.
Of course, yes. Any other learnings you want to add as well, or any differences and similarities?
Yeah, absolutely. I think workforce challenges, we all talked about that. I think having passionate people, and that's something that we really experienced firsthand, was the generosity, just the respectful way that staff talked about each other and the clients that they provide services to. And really passionately about the jobs that they do. And similar to Australia, you know, people work in this area not for the money. They work in this area because they really are deeply committed to the work and to improving outcomes for clients. And so I think we share that. That's a common language, spoken or unspoken. You can just feel it with all of the services that we visited. So I think that was huge. I think the other similarities are that we've got an ageing population, increasing complexity. So, you know, we talked about how do you manage that on a shoestring budget? You know, there's increasing need and not often increasing funding 100%. To go with it. So similarities and challenges all in the same hand.
Of course. Anything else you want to add, Tassia?
Probably the other thing is different funding models. The funding here seems to be really factored and organised around the client or the consumer need, whereas for us it's very much program focused. So we're really focused on achieving the targets related to that client, and very rarely do we have the opportunity to, you know, pull all the funding together that we get from different ministries, different government departments, and then do our own assessment as to what does that community need and implement the staff in to meet the needs of individuals. Right. So we're really tied to the funding. It would be amazing if we had that flexibility, because that would then bring a real integration, real wraparound services, and you get a better outcome. per client.
Yeah, of course. Now, Andrea, I know you mentioned sort of more directly what you hope to take back in terms of the peer support, but Tessia and Simone, I want to give you an opportunity as well. Is there anything in those learnings that you're like, we need to implement this in our community health center or over in Australia?
Community paramedic model.
Okay, yep.
We've had a couple of services enter that space, but it should be rolled out across the state. We need to use our nursing staff better as well, bigger scope of practice. There's a lot of learnings, we could write pages and pages, I think.
We will.
We are happy to hear that, yes.
And we absolutely will, and take it back, and, strong advocacy, for the broader health system as well.
Absolutely. How about you?
I think for me, the Flemington model. So we certainly work with community that have difficult access to all of the services, and to walk into that yesterday in a shopping centre and so established, and I know it took a very long time to get to that, but wow, what a health and wellbeing area for community that have considerable inequities, and a place that they can go and everything's there, so that working collectively in partnership and setting up a Flemington model, which is big vision, but wow, that would be fantastic for some of our areas.
Amazing, thank you. Now we'll go down the line. This is basically our last question, but I'm curious why you all think community health centers are a vital healthcare model globally, and why we should be advocating for them. So you look like you're just ready to answer me.
We know prevention works. We know that prevention absolutely works. We've all got crippling health systems, and so it really is important that we work out how to move that money that's already in the system from, from the areas that are using it huge amounts, and getting it out into the community where we know we get better health comes at a much cheaper cost.
Amazing.
There's an old African proverb or saying that often goes, health is made at home, hospitals are for repairs. And I really believe that, and I think that, community health is where it all comes together, and hospitals should only be used for the times that we need them.
100%. Thank you. Tassia?
Just the basics. Community health is embedded in the community and engages with community. We saw that through the COVID crisis across the world.
Yep.
There's no way, the hospital system or the acute system could have responded and engaged with the community in the pace that we were working in, and the trust. So they trust us, they feel comfortable to come to our services, and if we were to disappear, the health system would fall over.
100%.
That is the reality.
Yeah.
And emergency rooms are not coping now, we know that. So, the investment in community health services will pay off long term.
100%. No, completely agree. We have some of our Canadian version of these statistics on our website that talk about how much community health centers, like I'm sure that you were given this document, about how much our support lifts the burden from emergency rooms, how many millions of dollars we save the government, and yet sometimes it feels like those millions are not given back to us to help us continue to do that work. So that's part of the work that we need to continue to do over here. Leah, I just wanted to give you a final moment to reflect on any of the learnings or anything you were feeling about this visit before we wrap up the episode.
No, I think probably my first thing would just be to express our gratitude to the services that hosted us. It's a complex piece to pull together. The VHA hasn't done a study tour since, I think, about 2018, Tassia, is that right? So it's been a while, and pulling it together is tricky. It's been a busy week and a half, but there's been a lot to learn. I think what I've really enjoyed is that we've got individual take-homes that will be impactful at the service level, but then collectively we've all learnt a lot about the direction that we need to take as a sector. And then really we're keen to hear from our delegates that attended as to where the priorities are for the VHA. So we'll really be able to lift up the learnings into policy pieces, undertake some advocacy, we hope, to get some of the really important initiatives in front of government and funded. But great opportunity for us to learn. There's only a couple of jurisdictions across the world that have got thriving community health like what you have and like what we have, and I think we're all equally proud. So thank you for having us.
We're so happy to host. Thank you. And I feel like I would be remiss if I didn't mention that this is possible because of the Alliance conference done by the Alliance for Healthier Communities in Ontario. And so I've been coming to this conference for 4 years. You're going to learn so much over the next day and a half, and you're going to get to meet so many more amazing people doing great work. So we're so happy to have you. And I'll go down the line. If you want to mention where people can learn more about your specific organizations and then learn more about VHA.
Yeah, thank you. So I'm, as you mentioned earlier, I'm from Wholestep Health. Our website is www.wholestephealth.org.au. We run about 120 different services. We're the third largest community health service in Victoria and a recent amalgamation of two smaller organisations. So happy to share information. Please reach out, jump on our website. And we're happy to host you anytime too.
I'm booking that plane ticket. Do not worry. I've heard the rumors about the spiders and things I need to look out for, but I'm coming with a fly swatter and a passport, bottle of water, and I'm ready. I'm here. Do you want to continue?
So you can find our organisation at, how do I say it? Better. How do you say it?
Better, but it will.
I say better. You say better.
The screen will actually show it, so you don't even have to worry about your pronunciation because technology it's going to be right here, right now.
Better Health Network. www.betterhealth.org.au. Yeah, really happy to take any questions. Again, come and visit.
We will. And I think you had mentioned that you're doing amazing work in regards to sex work, correct? So do you want to plug yourself a little bit?
Absolutely. So we run the only statewide service for sex workers. Mm-hmm. So it includes health education, case management, clinics. We basically link our sex worker clients up with the support that they need. But it's a great organisation and it runs under a different logo called RED, R-H-E-D, cool. RED.
Perfect. I'll put that on the screen too. Thank you, because I knew that's something we don't really have, so I wanted to make sure Canada got to hear a little bit about that. And so tell us about your organization.
So North Richmond Community Health, and thank goodness you've got the website down here. Thank you very much. And our main specialty, we have two specialties really. Our main one is the medically supervised injecting room, where we see approximately 250 clients a day injecting heroin and manage an average of 15 overdoses a day, and it's a 7-day service. And then our other specialty is refugee health. So it was the refugee health that established our service 50 years ago, and we continue to work with both our communities in those areas of specialty.
And Lee, last but certainly not least, if everyone who should want to learn more about VHA at this point,
you can find the VHA at vha.org.au. But we are very well connected with the Canadian Association and with EWO and the team, and we're also part of the international federation that gets together and shares learnings, and we'd be very pleased to host a Canadian delegation. So
at this point, I think we have to. Amazing. Thank you all for taking the time to have this conversation and for being here. We really appreciate it.
Thank you.
Thank you for listening to Community Matters, a podcast from the Canadian Association of Community Health Centres. To learn more about our association and the important work of community health centres across Canada, go to www.cachc.ca.